everybody. My name is Alex. Welcome to our third installment of ECG Insights. I'm met here with Dr. Deshmukh, who's joining us once again for this session. Thanks for joining us.
Thanks, Alex, for having me.
All right. And thank you, everybody, for watching our previous two sessions. We've had a great response from everybody so far. So I think you're really going to like this the session that we've put together here this month. Haven't had the opportunity to see last month's session, feel free to do so to learn more about Dr. Deshmukh and kind of his background and whatnot. But he is an ECG expert and looking forward to diving into some of our ECG case studies.
Let's do it, Alex.
All right. So as usual, our learning objectives consist of identifying key features of ECGs, including heart rate, rhythm, intervals, and waveforms. And then also applying basic ECG concepts and sometimes advanced ECG concepts into recognizing common arrhythmias and conduction abnormalities, and as well as explaining core concepts as it relates to various allied health roles and their clinical significance. So let's go ahead and dive right in. All right. So last month, we kind of talked about kind of the general approach to ECG interpretation, including looking at our intervals and analyzing our ECG for the overall rhythm, the overall interpretation, but then analyzing the bottom leads for your overall rhythm as well. But kind of, you guys will notice a kind of a similar approach to the different ECG case studies that we'll be diving into. So really what I want to focus on is our upper 12 leads here and analyzing what leads are contiguous when analyzing for ST elevation and ST depression. So kind of one of the approaches that I like to take when we're walking through education of our technical staff is first starting out here in lead 1, because what sometimes happens is when you are brand new to analyzing a 12-lead ECG, you tend to your eyes tend to gravitate towards the middle here and even starting here in V1. So I like to start in the upper left-hand corner, starting with lead 1, and then also working with AVL. Those are your high lateral leads on your ECG. So those are your high lateral contiguous leads that work together. You then have leads 2, 3, and AVF, which are your inferior leads. So those are your contiguous leads. And one of the most important leads when you're with your inferior leads happens to be AVF, because based on that Einthoven triangle, that tends to be right in the middle between leads 2 and leads 3. And then moving over to V1, looking at last month we talked about having a R-wave progression, starting out here in V1, moving all the way through V6. But when you're talking about contiguous leads, your V1 and V2 tend to be your septal leads, then moving into your anterior leads in V3 and V4. These leads kind of all work together to form what we would call our anteroseptal leads. And then lastly, moving into V5 and V6, having to do with your low lateral leads. And so based on the way that your 12-lead ECG is approaching V5 and V6, as well as 1 and AVL are looking more at that lateral wall of the heart, V5 and V6 being a little bit lower with your electrode placement, tends to look at the low lateral portion of your heart. Dr. Deshmukh, would you have any other approach, or would you have anything to add in terms of looking at contiguous leads, assessing for ST elevation?
So, Alex, that's great. So it's important to look at the geography which is represented by the ECG leads, but that may not always show you the underlying lesion, because the coronary artery, although may go to the inferior wall of the heart, may also partly go to the lateral wall of the heart. The left anterior descending artery, although it is going to the anterior wall of the heart, may also go more septally, may also go more laterally, depending on which branch is getting occluded or involved from a STEMI standpoint. So it's important to look at the contiguous leads, but also important to look at any neighboring structure with that lead. So if it is an inferior wall, want to make sure there is no inferolateral changes. If it is an anterior wall, want to make sure there is no anterolateral changes. So make sure that we also look at the neighboring structures and neighboring territory also when we are analyzing these ECGs. But no, this is a great start as a primer before we dive deeper into some of the specific ECGs.
Absolutely. All right, so moving into our first ECG case study, Dr. Deshmukh, how would you approach this particular ECG?
All right. So let's look at this ECG. So you have lead 1, 2, 3, AVR, AVL, AVF, and then V1 to V6. Obviously, when you look at this ECG for the first time, what really jumps out of the screen is your lead V2. So look at lead V2. significant ST elevation. Lead V3, significant ST elevation. V1 has some ST elevation. So you clearly know now that there is an injury which is occurring to this myocardium. Now, when you look at this V1, V2, V3, as Alex pointed out, these are more your anterior and anteroseptal leads. And that is the territory of the heart which is supplied by the left anterior descending artery. So we now know that there is definitely involvement of this left anterior descending artery. And like I pointed out, when you're looking at the anterior leads, also look at the lateral leads. And here you can clearly see there is some ST elevation in lead 1 and AVL also, telling you that this is more of an anterolateral infarct. Now, if that's the case, when you look at ST segment elevation, we always talk about reciprocal changes. So that is the area of the heart which is not affected, but all the activation is, but you're trying to see all the reciprocal changes what you're seeing on that ECG. So generally for anterior wall MI, the reciprocal changes will be in the inferior leads. For inferior wall MI, the reciprocal changes will be in the anterior leads. So here, as the MI is more anterior wall, you can clearly see ST depression in the inferior leads and inferolateral leads. This is again suggestive of there is no ischemia there, but this is typical for the inferolateral changes which are reciprocal to this anterior wall leads. Now, a few other things what we can look at, if you take a step back, is to try to see how to look at ST elevation. Like what do we compare from to look at ST segment. So Alex, how do you think about it? And before I can add few points to that too.
Talking about the morphology of
Not
the ST
morphology, but where are you measuring the ST segments from?
Yeah, absolutely. So when looking at V1, when you're looking for your baseline and where your ST segment should be, you're looking right around here, kind of between the T wave and the P wave, following into the PR.
So maybe V3 might be better because you can see the TP segment here.
Yeah. So that's also basically your isoelectric line, and your ST segment should fall right where we drew here, right on that isoelectric line. And if we have a swooping effect that's right on the baseline, that's not uncommon, but ultimately our ST segment should be similar to our PT segment, our PR, and we are clearly above that in multiple leads.
Absolutely. So really when you're looking at the ST segment elevation, you have to compare it with some isoelectric baseline, which ends up being the TP interval. So based on that, if your ST segment have gone up, then that could be your marker that you have ST segment elevation. Another point to realize that when you are getting ST segment elevation, what is happening to the J point? Because J point is where the QRS meets the ST segment. So even the J point has to go up followed by an ST segment in patients with ST segment elevation MI. Because sometimes you might see ECG where only the J point goes up, but it's not pulling the whole ST segment up. But if you have clearly ST segment going up along with the J point, that could be one of the differential diagnoses for acute MI. Few other situations where you would see this would be pericarditis, would be benign early repolarization pattern. Some of those patterns may also show this J point elevation and ST segment elevation and ST segments going up. So just in your own, when you look at ECGs, Alex, you have any thoughts on how you would tease those things out? Say if a pericarditis ECG from an ST segment elevation.
Yeah, so some of the main things that we're looking for in the differentiating a true ST elevation compared to pericarditis, oftentimes you think of kind of diffuse ST elevation all over your ECG.
Yeah.
And so as you notice here, we have clear ST elevation, we have reciprocal changes, which is definitely more of an indicator of your anteroseptal STEMI, whereas pericarditis, you would see ST elevation also in your inferior leads and your lateral leads as well.
So if you think about just the pathology behind pericarditis, it is inflammation of the pericardium. And when an inflammation occurs, more often than not, it is not very partial that I'm just going to affect the anterior wall and leave the inferior wall alone, or I'm just going to affect the inferior wall and leave the anterior wall alone. So whenever you have pericarditis type ECGs, you will get diffuse ST segment elevation all across your leads. And another thing, typically you would see that the PR segment is downsloping. PR segment is downsloping in patients with pericarditis. So here you can see there is a very short PR interval, but in pericarditis, typically you would see the PR segment which is going down. Next, you don't see reciprocal changes in patients with pericarditis. So you'll get diffuse ST segment elevation all across, and you don't see a lot of pericarditis type changes. And finally, this is a very bizarre pattern. This much increase in the ST segment, you would not generally not see in patients with the pericarditis. So a lot of clues here about how you're going to differentiate this from an acute pericarditis type looking ECG. And because the PR segments are going down everywhere, the PR segment may go up in lead AVR when you're looking at a pericarditis ECG. So if this patient comes to the hospital, obviously with chest pain and in the right clinical situation, at least clinically, you should consider activating the cath lab or trying to get this patient to reperfusion therapy as soon as possible for this patient to do well over a period of time. A few other things what you could look here. This is an acute MI going on, but sometimes it's difficult. Not every patient will present with such a humongous ST elevation, and there the diagnosis can't be based on just one ECG. At least clinically, when you are in the field or when you're in your hospitals looking at these ECGs, important to get multiple ECGs every few minutes to look for any progression of the changes. Because if the ST segments are getting more and more worse or they are more dynamic, that again is your marker. This is likely consistent to be more with ischemia than any other pathology you're dealing with. Now we talked about pericarditis, how to differentiate. Second would be early repolarization. Now typically early repolarization is seen mostly in the inferior and lateral leads when it occurs. And that pattern it's quite variable. So one thing is that, the benign, especially the benign early repolarization pattern is more prominent when the heart rate is slower, and it goes away when the heart rate becomes faster. That's important to know with that. And generally the J point elevation is there, but it's not as high as typically you are seeing in this in this acute MI type situation. So a few other pointers how you can differentiate benign early repolarization ST segment. And again, if you see inferior leads here, the ST segment is actually depressed, so a little bit unusual, and even the J point has gone down, again a little bit unusual for a benign early repolarization pattern.
Yeah, and so like with early repol, you might see that J point elevation, then I'll let you see that J point elevated right here, and then it swoops down
right
into that ST segment, and that's kind of a good indicator right there. I oftentimes see that notching in that J point in V4, V3, where it's kind of most
prominent. Absolutely, yeah. Good, perfect.
Anything else on this one?
No, this is good. Now we'll look at a few other ECGs and then try to compare some of the findings on this ECG as well.
Absolutely. So somewhat similar to the previous ECG, this ECG is not as what I would consider acute, but it's somewhat related. It's not the same patient. But when we're overall looking at this ECG, we talked about in the beginning how lead 1, AVL, your high lateral leads, 2, 3 AVF into your inferior leads. I don't see really too much as far as ST abnormalities in these particular leads. But then as we get into V1 through V6, focusing once again on R wave progression, you kind of have your normal small R wave, but then your big S wave here. Your T wave is slightly negative, but that's pretty normal for V1. But then as you progress into V2 and V3, you get this little notching pattern, this QS morphology in V2 and V3, which is very abnormal in most cases. You want to see that normal R wave progression where you see your R wave transition from being small here to getting more positive, transitioning to where you see that normal progression here in V5 and V6. So there's something happening here in V2, V3, V4.
Absolutely. And again, when you look at normal R wave transition going from V1 to V6, there's a small R wave and a deep S wave in V1, as you pointed out. But as the R wave goes from V2, V3, V4, V5, V6, the R wave becomes taller and taller, S wave becomes smaller and smaller, and by the time you reach V6, there is no S wave, as you can clearly see in this ECG. So here V1 is good and V6 is good. Everything in the middle is not so good. And that is this QS pattern as you're seeing in V3, V2, V3, and V4. And again, if you remember from last time, whenever an activation is going towards an electrode, it makes a positive wave. and whenever an activation is going away from the electrode, it makes a negative wave. So in a patient with a anterior wall MI, the MI is myocardial necrosis. After infarction, the myocardium gets necrosed, transmural infarction. What that means is that if you have a myocardium there, this whole thing is dead or scarred up after a period of time. And if that's the case, there is no way electricity can go here because this is all dead, but the electricity or some surrounding areas can start from there, and whenever an activation is starting from there, you get a negative wave. Activation going towards an electrode makes a positive wave. Activation starting from an electrode makes a negative wave. Because now the activation is starting from V2, V3, V4, you don't get that R wave, you're just getting all Q wave because all this area is quite scarred. Another thing, as you pointed out, was the notching in the QRS. So why is this notching occurring? Again, when an activation is going towards an electrode, you get a nice little R wave. But if there is some traffic or obstruction when this activation is going from one place to another, that obstruction or slowing of conduction gets manifested as notching, because now instead of a beautiful QRS, you will get a little bit of notching in that QRS, what you are seeing here. Now here the activation is starting from there, so that's why you get a little bit of notching in that QRS, suggesting again dead area and also some area of slow conduction here with this notching. That's again a marker of unhealthy myocardium as noted in that area. Now here V2, V3, V4 up to the apex, there is no R wave, and now the transition is very late. So if you see really no Q wave, no R wave V1 to up to V4, you also know that R wave, which is basically activation going towards an electrode, so not much activation going towards the anterior wall. That is also one marker that the ejection fraction is going to be slightly compromised in this patient. Another interesting finding, if you remember, we talked about the ST segment. If you see there's slight elevation in the ST segment here, V2, V3 and V4. So if you have persistence of ST segment elevation in setting of Q waves in the anterior leads, that's also one of your marker that you may have little bit of akinetic or dyskinetic LV apex, or can be consistent with LV aneurysm type changes. So that again can occur after an anterior wall MI. So this is a subtle evidence of that also on this ECG. So certainly lots going on in this ECG, but again remember the inferior lead, if they were not affected, completely pristine looking inferior QRSs in the inferior leads. Same thing in lead 1 and AVL, they look pretty good. So this is an example of an old anterior wall MI, maybe some aneurysmal type changes or at least a dyskinetic apex.
Yeah, and that kind of gets into your point of what you talked about in the last ECG, getting serial ECGs to see the progression of the ST elevation or the persistence of this type of abnormality where it might lead to something like similar to a ventricular aneurysm.
Absolutely, great. A very nice ECG.
Yeah, so overall, when you look at the measurements of this ECG, it just by pure measurement standpoint, looks to be a pretty normal. However, when you do that assessment of your ST and T waves, clearly an anterior wall infarct.
Infarct, yeah. Great.
All right. Getting to ECG case study number 3. It's when you first look at it, it's very slow. And there's a few things that stick out to me when you're looking at this ECG. Starting in lead 1, kind of like where I like to usually start, you clearly see ST depression and AVL as well. Usually one of the things that I say, if you see ST depression, look for elevation, because sometimes that might be the case where you might focus on the ST depression, but there might be ST elevation somewhere else on your ECG. And so clearly in leads 2, 3, and AVF, you have very prominent ST elevation. And then I wouldn't stop there. When looking at our V leads as well, you kind of have slight ST depression in V2, V3. V4 looks okay, but then you also have ST elevation in V5, V6, also the presence of slight Q waves as well. So there is some lateral wall involvement as well. So overall, looking at an inferior lateral STEMI.
Yeah. And how about the rhythm?
Yeah, it's obviously very slow, but when you look at the rhythm starting here in lead 2, when you follow your P waves all the way across and you compare your PR interval, there's a hidden P wave right in here. PR is much different compared to the first complex. PRI is varying all the way across your ECG. Your P to Ps are regular. Your R to Rs are regular, occurring at 2 different rates. So it looks like we're looking at complete heart block.
Absolutely. So inferior wall MI and complete heart block, very, very common combination what patients can get. So there's a lot going on this ECG obviously, but let's just highlight on a couple of things here. So let's go to the next screen and let's think about this vector diagram again. So your AVF, as you pointed out, is between your lead 3 and lead 2. Lead 1 is here, AVL is here, and AVR is here. Okay. So again, when we talked about activation going towards an electrode makes a positive wave, activation going away from the electrode makes a negative wave. Even if people understand this concept, the rest of the entire ECG life becomes very, very easy. Now this is the left side and this is the right side. So lead 3, as you know, is on the right side, AVR is on the right side, 1 AVL, 2 AVF are on the left side, and AVF, as you pointed out, is more center part of the triangle of Einthoven. Now imagine there is a right coronary artery, which I'm going to draw, which is looking like this. Okay, so this is the right coronary artery in the LAO view, or left anterior oblique view. So again, if you just imagine this is the right coronary artery. So right coronary artery, the interesting part about it is it starts in the right side. So you get some contribution from lead 3. It goes in the middle, some contribution from AVF. And it also goes to the left side, so some contribution from lead 2, and then it divides, you know, to 2 different branches, the posterolateral branch and the posterior descending artery. Now, if you think about that, it's important to know you can predict where the MI is based on where the ST segment is maximally elevated. So if the ST segment is maximally elevated in lead 3, you're going to have a more proximal to mid RCA involvement. If it is AVF, you're going to have more kind of mid to distal, and if you have lead 2, AVF will be more mid, and if you have lead 2, which is maximally elevated, it's going to be between your more mid to distal and beyond that part of the right coronary artery. So just even if you forget about AVF, lead 3 ST segment elevation much more is going to be more proximal to mid, and lead 2, if ST segment is more elevated, that's going to be more mid to distal. So that's how you would know. And now lead 2, because also on the left side of the heart, if lead 2 has more ST elevation, then the left-sided leads, which are basically a V5 and V6, which are the more lateral leads of the heart, will also be implicated if you have an inferior wall MI which is more towards the left side, as we saw from that ECG. So if you go back to that ECG, Alex, you can clearly see you have ST segment elevation, but you can see your ST still elevated in lead 2, but you already have a Q wave now in lead 3 and lead AVF.
Absolutely.
The ST segment is still high, but you look at the Q wave. The Q wave is maximum in lead 3 compared to AVF compared to lead 2. So that's also your marker that, you know, your more proximal to mid RCA was involved much more compared to more distal RCA. Because once this acute MI evolves, you will get a Q wave, but the Q wave has already occurred. So you have ST elevation, but the cells are already dying here, giving you that Q wave in the inferior leads in lead 3. That may again tell you it is more like a proximal type lesion. Now, why does that becomes important? If you go back to our next slide, is that if the lesion is here, then you are going to affect everything which is occurring downstream. And that's why you have subtle ST elevation in V5, V6. But more importantly, you need to understand how the blood supply of the coronary artery and how it supplies the various electrical system of the heart. So you have electricity starts in the SA node, goes to the AV node, bundle of His, and left bundle, right bundle, and left bundle. So left bundle, right bundle, His, AV node, and SA node. Now, and this is your right coronary artery. Maybe I'll draw the right coronary artery with a different color. So this is your right coronary artery. Now the AV node is supplied by the right coronary artery. The SA node is supplied by the right coronary artery and in small circumstances also from a branch from the left circumflex artery. AV node also has a dual blood supply. It is coming from the proximal half of the AV node is supplied by the right coronary artery, and in some instances the distal half can be, and in some instances the distal half is supplied by the left anterior descending artery. The bundle of His is exclusively supplied by left anterior descending artery, the septal branches. Same with the right bundle and left bundle. So right bundle is supplied by the left anterior descending artery. The left bundle is also supplied by the left anterior descending artery. Now why this becomes important is to know if one of the artery gets involved, what are the risk of complete heart block. Now the SA node is supplied by the proximal or the ostial part of the right coronary artery. So if you have a very ostial RCA lesion or ostial RCA thrombus, then you could get ischemia to the SA node. And generally ischemia to the SA node may present as junctional rhythm, so that because there is no blood flow going to the SA node, maybe you can infarct the SA node so that you are getting junctional rhythm. Another thing would be sometimes patient present with atrial fibrillation, and that is because of atrial ischemia. That may also suggest that you have a very proximal RCA lesion which is compromising the blood supply to the atrium. When you go from proximal to more mid RCA, it can affect the AV node here, as you saw in that ECG what you showed. So this patient has had a complete heart block, but by and large patients with inferior wall MI and complete heart block, the complete heart block may get better over a period of time. So you just have to wait at least for a few days, and if it doesn't get better over 96 hours, then a pacemaker can be considered, because this AV node has dual blood supply, partly from the right coronary artery but little bit from the LAD. But now if you have complete heart block because of an LAD infarct, that means you have infarcted the His, that is never going to get better because you don't have dual blood supply for the His bundle. So if you have a complete heart block in setting of LAD infarct, that is not going to get better. So the ECG, the first ECG you showed of STEMI, that patient had an LAD infarct, fortunately did not have complete heart block because that complete heart block would not get better. It is not also uncommon to see sometimes new left bundle branch block in patients with anterior wall MI or MI involving the left anterior descending artery. That is because of ischemia to the left bundle. It's also not uncommon to get right bundle branch block in patients with anterior wall MI and LAD territory infarct, because the LAD also supplies the right bundle. So that's why if you get a new bundle branch block in a setting with an MI, that cannot be from an inferior wall MI because the right coronary artery does not supply the bundle branches, but that's almost always because of the left anterior descending artery and the septal branches. But key thing is complete heart block, because complete heart block can occur both from inferior wall MI and anterior wall MI. Anterior wall MI with complete heart block doesn't get better, so the patients would need a pacing device right away. The inferior wall MI patients with complete heart block may not always need a pacemaker, and if you watch them or put a temporary pacemaker and give it some time, those AV blocks may get better over a period of time. So just from AV block standpoint and the ischemia standpoint, it's important to know which AV blocks are very concerning and requiring urgent pacing compared to which we can certainly sit and watch. Now, another thing would be if patient has complete heart block in setting of inferior wall MI, that means AV node is compromised. So if you give atropine, you may potentially improve conduction in the AV node and see if they respond to that. But if you give atropine with a patient with block or ischemia of the His bundle, that is not going to get better because the vagus nerve doesn't go to the His bundle, so atropine is not going to work out there. So at least few couple of bedside tricks you can also do to see if the AV conduction is getting better with atropine. It may not always get better, but sometimes if you see a clue it is getting better, another reason you can just sit tight and watch and see how things go over the next few days.
Absolutely. So taking some of the things that you were talking about in this particular ECG, so we're having inferior STEMI and we result in complete heart block, so that AV node where the RCA is supplying the AV node, it's causing this patient to go into complete heart block. And based on some of the things that you said, best case after the STEMI is ultimately reperfused. give it a little bit of time in order to see if the intrinsic electrical activity kicks back in. Otherwise, it may result in a pacemaker.
You can also see this, you can just looking at this ECG, you can know now what are the reciprocal changes. As you are seeing more ST elevation in the inferior leads, the reciprocal changes, so opposite to the inferior lead is going to be anterior. So these ST segments are down in the anterior leads because of the reciprocal changes. This is also an example to say that this right coronary artery is quite large or dominant, because although you have more proximal to mid RCA involvement, even your lateral leads have ST segment elevation. So it's a very, very big artery which is getting compromised from this infarct. Again, some of the ECG clues to tell you how big the artery is, dominant artery, where does it supply, and then the reason for complete heart block in this situation. Anything else you see, Alex, on this ECG?
Nothing else that I see. But
One thing I see, if you look at the sinus rates, they are not very fast and they are a little bit slow. So it is not uncommon that in patients with inferior wall MI, they can get a very high vagal tone. So that can cause bradycardia, because if it was truly infarction of the atria, then you would not get a P wave. But the fact that you see, it can cause some bradycardia also with some atrial ischemia. But it is one reason why patients can become bradycardic during an inferior wall MI just could be high vagal tone because of pain and everything else. So that can also occur with this sinus rates.
Yeah. Sticking with kind of the sinus rate, the other thing that you notice here, it says ventricular rate is 35. Every once in a while I'll see where somebody will call this particular ECG sinus bradycardia with complete heart block, when in reality the SI node is firing normally here, right around 70 beats per minute. So it wouldn't be sinus bradycardia, because your sinus rate from P to P wave would just be sinus rhythm with complete heart block and that junctional escape focus.
So again, in this situation, if you give atropine here, the AV block may improve, but definitely the sinus rate will go up, because the sinus node gets both the vagus nerve and the it has both vagal and parasympathetic and sympathetic inputs. So with atropine, you're going to block the parasympathetic input. Your sinus rates may go up with atropine in these patients. But key thing to remember or to look at if the AV conduction gets better.
Absolutely. But at the end of the day, with this type of a situation, from a technical standpoint, rapidly recognizing that this is an inferior lateral STEMI, you're having reciprocal changes which would result in emergent communication to the ER in order to improve that door to balloon time, getting that patient into the cath lab.
Absolutely.
Moving on to ECG number 4. Clearly, we do not have ST elevation in, similar to that previous ECG. Looking in leads 1, AVL appears to be pretty normal in terms of P wave, QRS, T wave. Looking in your inferior leads, you do see a little bit of an abnormality here that sticks out to me in terms of looking for pathological Q waves that you see here. Looking at V1, V2, V3, the first thing that sticks out to me right away is more of an RS complex, more prominent RS complex in V1. So if you're focusing on R wave progression, this is a pretty abnormal V1. It doesn't stick out to you, it doesn't scream at you, but you notice right away that R wave is a little bit taller than your S wave. And then same thing here in V2. So, and then also in V3. So having a more prominent R wave in V1 when you're talking a potential inferior MI or inferior infarct, this would be maybe an indication of a posterior
wall MI. Absolutely.
Yep.
If you can, again, think about how the ECG leads are placed. If you have 3 AVF and lead 2 which are present here, the key thing to find out where is V1. So V1 is in the right fourth intercostal space, so it's quite anterior. So any activation going towards V1 will make a positive wave. Any activation going away from V1 will make a negative wave. And normally in ECG, you have a small R wave and a deep S wave in V1 because all the activation is going towards away from V1. The inferior wall MI, you're infarcting the posterior and the inferior wall of MI. So really, all the activation is going to start from there. That's why we are getting this Q wave in 2-3 AVF, because activation cannot go there. It has to start from there. And if it is starting from the inferior wall, it has to go more anterior. And if it goes anterior, if you have inferior wall and posterior wall MI, then it is going to go more and more anterior. So that's why if you get a prominent R wave in V1, that's also a marker that you have had a posterior wall MI along with an inferior wall MI. Now, a few other conditions when you would get a prominent R wave in V1, if you don't have to remember it, but that would just tell you that the activation is all going towards V1. So activation is going towards V1. That means it is going anteriorly. So it has to start posteriorly. That means it has to start from the left ventricle. So that means anything which is depolarizing the left ventricle first would cause a prominent V wave in R wave in V1. So that would be any left-sided accessory pathway, any pacing which is occurring from the left side, right bundle branch block because activation is now starting from the left ventricle, certain rotations of the heart, Duchenne's cardiomyopathy, some variants of hypertrophic cardiomyopathy are some of the causes why you would get a prominent R wave in V1 in certain patients. So this is again a nice ECG to illustrate that in setting of an old inferior wall MI, patient probably also had an old posterior wall MI, and that's why you're seeing V1 showing a prominent R wave.
Absolutely.
Anything else you want to add on this ECG, Alex?
I don't think so.
So, when we're looking at ECG, obviously we are focusing on MI, but anything from the P wave you can look at, just to digress the topic a little bit? P wave enlargement maybe?
Ooh, yeah. When you're looking at lead 2, the P wave from a duration standpoint seems to be a little bit lengthened, and you're also having a little bit of a notching effect.
Notching of the P wave.
And then also the negative deflection in V1.
V1. And again, that tells you this whole vectors how the heart works. Activation going towards an electrode makes a positive wave. Activation going away from the electrode makes a negative wave. So again, if you look at V1, it is placed in the right fourth intercostal space. So any activation going towards V1 makes a positive wave. Activation going away from the V1 makes a negative wave. So if you look at P wave in V1, it is almost always initial part is positive, terminal part is negative. And that's because SA node is a posterior structure. So activation is going more anteriorly. So it makes that initial positive P wave. And then the rest of so that's the RA activation. And the rest of the negative is basically the LA activation. That is the vector going away from V1. So if you have a situation where there is right atrial enlargement, so the initial part becomes taller and taller, and the terminal part is normal. If you have left atrial enlargement, then the terminal part becomes more broader, and you may miss out or the initial part might be smaller, and you may even miss it. So here you can see there's mostly terminal part which is negative, more notching in the inferior leads, again suggestive of some left atrial enlargement as you are seeing in this ECG. So always, obviously we want to look at the big picture, but as a student of electrocardiography and ECG, as you're learning, try to look at the whole ECG and see if you can understand any other things which are going on in this patient's ECG.
Absolutely. Right. And just finalizing our topic about the inferior infarct. So this is definitely what I would consider more of a slam dunk inferior wall infarct because you have your pathological Q waves in 2, 3, and AVF. Depending upon the size of your infarct, it may not always be that way. And so once again, your primary lead that you want to look at least from our standpoint, is looking at AVF, because that's right in the middle. And then you might have involvement in either lead 2 or lead 3. But AVF is kind of the one that sits right in the middle.
Absolutely. And again, going to initial point, it has to be 2 contiguous leads, because if it is just an isolated lead, then it is not a definition of a old myocardial infarction. It has to be in 2 contiguous leads also.
Yeah. It seems to be it's fairly common in lead 3 where you just have an isolated Q wave.
Right.
Doesn't necessarily mean it's pathological, because we also need to have the correct measurement of at least 30 milliseconds. And then 2 contiguous leads in terms of pairing that with AVF or lead 2.
Perfect.
Now, getting into this particular ECG, we're adding in a little something extra in terms of we have ST elevation and ST depression, but we also have a wide QRS complex based on our measurement, and our heart rate is faster, and our computer's having a hard time picking up a P wave.
Yes.
So when looking at lead 1, AVL, you have if you're looking at your PT segment, looking for your baseline. You have ST depression and J-point depression here as well. Same thing in AVL. Looking at 2, 3 in AVF, you might have slight ST elevation here in lead 2. Our baseline, it's hard to kind of follow that a little bit, but clearly in lead 3, clearly in AVF, you have clear ST elevation. Looking at V1, V2, our QRS complexes are immediately going positive, and you're having notching, kind of leads into the QRS might be wide. And then by the time you get over to V4, so you do have ST depression, but there might be more of a reason for why that ST depression is there.
So normally you would get an ST depression with right bundle branch block and T-wave inversion sometime, but this is quite pronounced, and this is just probably some reciprocal changes what you're getting from the inferior leads.
Absolutely.
Yeah.
By the time we get over to V5 and V6, we get our wide S wave because of that right bundle branch block, like you mentioned. And to make things a little bit more difficult, it's a little bit more of a rapid ECG. I don't see consistent P waves kind of sticking out, maybe some things that might look like P waves every once in a while. So overall, maybe thinking that this ECG is likely to be atrial fibrillation.
Absolutely. Clearly atrial fibrillation, and you can see it in patients with inferior wall MI, because sometimes patients can get atrial ischemia, so that can cause atrial fibrillation. It could also be the stress of MI, increased sympathetic tone, which can put patients into atrial fibrillation. But like we talked from the earlier ECGs, this right bundle branch block is not because of the inferior wall MI. This patient probably had a right bundle branch block before, so that you can rule out from ischemia from the right coronary artery standpoint. And the prominent T-wave inversions, what you are seeing here is just addition of the reciprocal changes, what you are seeing from the inferior leads.
Yeah, because on one of the previous ECGs, you mentioned that the right bundle is primarily fed by the LAD, and we're talking about more of a inferior wall MI.
Yeah.
Yep.
Great. Anything else you would see, and maybe next time when we talk about bundle branch blocks more in details, you can see one of the markers that you have right bundle branch block is that means you have no or less electricity going down the right bundle. This is irrespective of acute MI, and you will always get this slurring of the S wave in V6. So again, normal QRS is summation of LV activation and RV activation. So the LV activation, which is onset of QRS, goes down to the deep of the S wave. It's all LV activation, which is normal. But this RV activation, which is the terminal part of QRS, is very slow. That is because the right bundle is blocked, as you can see in this patient from this ECG. So because the bundle is blocked, the rest of the right ventricle is getting activated from muscle to muscle conduction rather than through a His bundle or a right bundle, and that takes longer time, and that's why this S wave is broad and slurred in patients with a right bundle branch block. Typically, you would see it often in leads 1, V5, lead 1 also you can see it, in V6 you can see it. So this terminal slurring and slowing is just because of slowing conduction in the right bundle, in the right ventricle, sorry.
Yeah, and like you mentioned earlier, when it comes to a right bundle branch block, it's pretty common to see secondary ST and T wave abnormalities following abnormal ventricular depolarization from a right bundle branch block. However, this is more pronounced and is likely more due to the inferior wall MI.
And some reciprocal changes.
Yeah.
Nice.
All right, and then getting into our last ECG case study, which sometimes tends to be pretty challenging. We've talked about all of our other leads except for one. Mm-hmm. And so when you look at lead 1, AVL, you can see your clear P wave. So when you're looking at your overall rhythm, it appears to be sinus in origin, but then you have clear ST depression in A1 and AVL. So our high lateral leads, our inferior leads 2, AVF also appear to be depressed. Lead 3 appears to be okay. But then we have slight elevation here in V1, but then depression in the rest, V2, V3, V4, V5, V6. And then lastly, one of the leads that we haven't really talked about, AVR, where you have clear ST elevation.
Yeah, absolutely. No, this is a nice example where it's telling you the opposite story, because now you have reciprocal changes on all the leads and you have a true change in only one lead. So this when this happens, this is consistent with like a very proximal LAD or a left main disease. And it's very easy to explain also, because if you go to the next slide, it all depends again on the vector principles. So your lead V1 is placed here, V2 is placed here, V3 is here, V4 is the apex, Then you have V5 and V6. And lead 1 is here, as you pointed out, AVF is here, 2 is here, 3 is here, AVR is here, and AVL is here. Now, if you look back at that ECG, can you go back to that ECG? You will see significant ST depression, V2, V3, V4, V5, V6. And if you think which leads have the maximum ST depression, you would see lead 2, lead 1, and then V4, V5, V6, and V3. So look at the leads which have the maximum ST depression. Now go to the next ECG. So all those leads are here. All these leads have maximum ST depression. So when we talk about ischemia and infarction, we talk about this concept of reciprocal leads. So if you have significant changes here, it should get reflected in the lead which is opposite, reciprocal to it. That is going to be your AVR. So because in AVR, so whenever you have so much ST depressions in all these other leads, you have to look at AVR. So that's the reciprocal to all these leads, which is on the right side. And that you can also pick it up a little bit on V1, but basically AVR, which is more higher, giving you a more global picture of this whole LV apical apex type location. And if it is exactly opposite what the information here is showing you, so everything is depressed here, so just this one lead will be elevated. If you go back to that ECG, you can clearly see AVR, which is ST segment elevation. So if you have AVR ST segment elevation and everywhere else it's depressed, mostly the leads opposite to the AVR on the left side, then that is going to be consistent with the reciprocal changes because of significant ischemia going to the rest of the ventricle. So if you go back to the next tracing, so if you look at, so this is the left side, this is the right side. So if this quadrant is one which is maximally involved, the reciprocal to that is going to be this quadrant, and that's why you'll see the AVR changes here. If you just have little bit of right coronary infarction, the quadrant opposite to that is AVL. That's why you see changes in all this area, V1, V2, 1, AVL after an inferior wall change. That's the reciprocal for those leads. So sometimes just looking at these simple patterns can help us identify where the infarction is. Is it truly ischemia or is it reciprocal changes? And then we can tease out a lot of these things. Now, mind well, in reciprocal changes, you get ST depression, but you don't get T wave inversion. If you go back to our ECG again, here you have significant ST depression, but the T waves are looking pretty good. So that one thing you need to remember, that in reciprocal changes, it's a reciprocal changes to the ST segment, not to the T wave. It's reciprocal changes to the ST segment. So if the ST goes up, the ST goes down in certain other leads. So that's your reciprocal changes what you look at. Now this concept is also important because sometimes it's very hard to know there is ST segment present or not present from elevation standpoint. And over the next few series we'll look at certain ECGs like that. But if you just have some subtle ST elevation in couple of leads, try to look at what is reciprocal to that. If that reciprocal part is showing the ST depression, then in your mind you should think, well, there is real ST elevation going on. If there is not much reciprocal changes, then you can potentially, get serial ECGs to prove that. But if you have subtle ST elevation in a couple of leads, try to look at what is reciprocal to that and look at if they have ST depression in those leads. And that can also help you sometimes guide whether this patient is actually having an acute MI or not. But acute MI again is not a ECG diagnosis, it's a clinical diagnosis. You need to have symptoms, you need to have biomarker changes, and you need to have ECG, and all those things will put together is going to make us a diagnosis of acute MI.
Absolutely.
Great.
As far as AVR, I know you mentioned like on this slide, based on the ECG, is that also a reason why we might have slight ST elevation
in
here
V1, as you nicely pointed out? Because if you go back to the next screen, your V1 is here, so it's away or opposite to all these other leads. So that's why you're getting a little bit of ST elevation here, but this is still at the same level, but this is even higher, it's more superior. So you're seeing more of that reciprocal change, and that's that ST segment elevation you're seeing in lead AVR.
Yeah, compared to like a true, because this is isolated to V1, true LAD involvement would likely include V4, V3, V2, maybe V1 as well.
Correct, yep.
And that concludes our session on our third installment of ECG Insights. Thank you everybody for tuning in. Thank you, Dr. Deshmukh, for joining us.
Thanks for having me.
Yeah,
Thank you.
We'll see you next time.